Hello, everybody. Welcome to the PCR webinar. It's a great pleasure and honor for me, together with this esteemed speakers and also the panel, to talk with you about mitral disease and the interventional options in mitral disease. The good thing and the fantastic thing is that we are really supported by Abbott in this webinar, and we try to answer all your questions. So before we go in the talk, please use the Slido tool to send in your questions, and then we will try to discuss all your questions. With no overdue, I will go over to Saibal Kar, who is talking about the 2021 guidelines, what's new, and we are very happy to have Saibal Kar here with us. Saibal, the stage is yours.
Ince, it's very nice to see you. You look younger than before. In 2 years with COVID, you made to look younger.
I've been treated with the clip, that make me look younger.
Stefan looks young too. So I'm going to thank you very much for this invitation. And I'm going to talk about the 2021 guidelines from US to Europe, what is new. But I have to acknowledge that the people on this webinar, some of the physicians from Europe, are one of the absolutely pioneers of this procedure. And I'm honored to be with them today. Next slide. So you can see over here the key changes that have taken place over years. You see, this has been a long journey of MitraClip, starting almost somewhere around 2005, when I remember doing my first cases, till the European approval around 2009. And then we had several important clinical trials that took place, including important registries in Europe, and culminating in two very important trials, the COAPT and the MITRA France. And then, of course, a few more trials coming up, for example, on tricuspid regurgitation. And then we have studies now on repair MR. So based on this, there has been changes on the guidelines. Can we go to the next slide? So the first thing I would like to talk about is the recommendations. Can someone make my slides bigger? Recommendations of TR for management of the term transcatheter edge-to-edge repair has been used as the new term, even though personally, I don't think this is the right term. The right term should be leaflet apposition, because what we do really in transcatheter mitral valve repair with the MitraClip or with Pascal is actually leaflet apposition, not really just edge-to-edge repair. Stefan, do you agree with that?
Absolutely.
Yeah. So based on the new guidelines, we can see over here that basically the transcatheter edge-to-edge repair has been approved for high-risk patients with degenerative mitral regurgitation. And I think the same guidelines are true both in Europe as well as in the US. Next slide. The definition of basically class of recommendations is a class of recommendation that's level of evidence. And when we come up with these guidelines, we use two terms, class of recommendation and the level of evidence. For example, if you have two randomized trials supporting a same hypothesis, then it becomes level B. Level A. If you have one randomized trial, then it's level B, and if you just have current guidelines, it's level C. So the level of evidence doesn't necessarily have to mean a bad thing. But for example, you may have just no randomized studies and a lot of clinical experience. It's level evidence C. Now the class of recommendations are divided from 1 to 2A to 2B to 3, and they must remember. Class 1 is what you really need to know when it's clearly indicated where the risks outweigh the benefits and it's the right thing to do. Class 2 means it's moderate. That means the benefits outweigh the risks and maybe, and class 2B is where the risks potentially are slightly high, but there are benefits. And class 3 means you should not be using those devices. With that in mind, let's go to the classifications. Next slide. So for the recommendation for patients with valvular heart disease, transcatheter edge-to-edge repair was put in as 2B, level of evidence B, And now it's actually made in the new recommendations, class 2A, level evidence B, non-randomized. So I'll try to explain to you why it's made as it's made. Number one, it's given a class 2A. That means we do know, that means the people and the body are convinced that the benefits outweigh the risks in this category. The reason why it's been level evidence B and non-randomized is because there was no randomized trial that led to the approval for high-risk DMR. It was a combination of Everest 2, which showed it was safe, and the high-risk registry, which showed that it was effective and safe even in a high-risk population, but that was a non-randomized data. And I remember, Stefan, you were there in the FDA panel, remember? Many years ago.
Yes, 2013.
15. And that has led to it as a class 2A recommendation. So I think this is very good to know. And in fact, I was quite upset that it was 2B, but now it's with the accumulating data with how safe it is especially from the NCD data, it has now become a class 2A recommendation. Next slide. So the primary MR pathway, this is the treatment pathway to primary mitral regurgitation. We believe that the first thing is that you diagnose primary MR, both by echo, and then you assess the severity also by echo, and also you assess the clinical symptoms based on clinical examination and history taking. And then you can classify the patients based on their anatomy into simple anatomies or not simple anatomies. And the recommendations are that if you are symptomatic with severe degenerative mitral regurgitation, we assess your risk status. If your risk status is low or intermediate, then you should be considered for surgical repair. If you're high risk based on the comorbidities, then you should, and your anatomy is suitable, then you should consider for a MitraClip procedure. Does any other suggestions do you have, Stefan, on this point?
Nope.
Yes. So where the recommendation has changed is clearly it has now become a 2A recommendation. And I think this is very important. I don't know whether this is important in Europe as well as in the US, but in the US, this is very important to become a 2A because what it is that now insurance companies will most likely pay for it. For the Medicare, it was not a problem. Medicare, they paid for the procedure. But for certain private insurances where the patients were younger than 65, we had challenges getting approval. But I think with this increase, going up to 2A, this will actually help us to get now insurance, get patients paid for the device. Next slide. So here's what we are talking about, the class 2 now existing in TMVR. So there is no existing TMVR recommendation for secondary MR, including mitral valve surgery. So the 2A guidelines for the management of patients with valvular heart disease this was the original. In 2020, for the first time, we got an indication for management of patients with secondary MR. And the indication class of evidence was 2A. And everybody knows the two trials, the COAPT trial and the MitraFrance trial. If the MitraFrance trial did not exist, most likely, I think it would have been a class 1A recommendation, or at least a 1B. Do you agree with that, Ince? And now,
B, but rather in the US, so there are certain other things. I'll highlight them next talk. Yeah.
Okay. So, but anyway, going back to the recommendations, we clearly they have given a clear-cut recommendation for secondary MR, but they followed the criteria that was in the COAPT trial. That means EF of less than 50%, NYHA class 2, 3, and 4 on optimal GDNT. And I think it's a reasonable option with appropriate anatomy. And I think it's a very important indication because it's 2A, and the level of evidence was B randomized. And the word B randomized is because there's one clear-cut trial which showed it was beneficial. The other trial was neutral. However, I feel that as we see the MitraFrance trial long-term follow-up, I'm beginning to see some improvements of heart failure admission. So I think if you combine both, we still think the level of evidence is very high. Okay, next slide. So these are the pathways. This is a very complicated slide of recommendations of MR decision pathway for secondary mitral regurgitation. But what is important is that when you see a patient with secondary MR, it is important to make sure that these people are optimally medically managed. Now, it's very tricky because people ask me this question, should they be completely optimally managed prior to be treated, or can they be done concurrently? So what I tell people, I said, look, you should at least see that they're getting the appropriate treatment and they're not, and they're euvolemic when you estimate the MR. And the blood pressure should not be too high. If in that situation, the MR is still significant and his anatomy is suitable and the EF is within the parameters of 20 to 50%, then I think the patient is a good candidate for MitraClip. Now, the good guideline thing is that all they need is another heart failure specialist to actually acknowledge that the patient is high risk, is appropriately treated. It is not necessary in the United States that a cardiac surgeon has to see a patient with secondary MR. So we highlight over here the tier highlights for the guidelines is MitraClip has shown clinical evidence and the foundation for a newer tier guideline recommendation. The MitraClip therapy's clinical body of evidence gathered over 17 years serves as the foundation for tier recommendation for both primary regurgitation as well as secondary mitral regurgitation. TIER has been upgraded to Class 2A recommendation for high and prohibitive risk primary MR patients. Upgrading the original 2014 Class 2B recommendation, there's a recommendation of TIER expanded to include high-risk patients because the original term was actually prohibitive risk. Now people use the word high risk, and high risk by the new ACC guidelines means if your STS is greater than 6% for repair or 8% for replacement and has one of few comorbidities. TIER is a new Class 2A recommendation for secondary MR patients with persistent symptoms despite optimal medical therapy. TIER is recommended by the COAPT-like subset of patients with severe secondary MR. Optimal GDMT is to be determined by a cardiologist expert in heart failure. It doesn't necessarily mean that he has to be a board-certified heart specialist. It can be any cardiologist who's comfortable with treatment of heart failure. What is very important is that in the US, the patient does not necessarily have to be even seen by the second physician. If the other physician actually reads the chart and looks at all the data and feels that the patient is optimally medically managed, it is appropriate to consider the patient for MitraClip for secondary MR. And I think that all clinical trials for secondary MR should have the control arm as a MitraClip. Next slide.
Thank you, Saibal. Thank you very much. Really, are you still continuing?
The European part is following, I think.
Yeah, so now we go on to the level of evidence of European. So you can see the definition of class of recommendation and level of evidence is almost similar to the US guidelines, very similar. Next slide. So over here, the 2021 guidelines for the diagnosis and treatment of acute and chronic heart failure, percutaneous edge-to-edge repair should be considered in carefully selected patients with secondary MR, not eligible for surgery and not needing coronary artery revascularization, who are symptomatic despite optimal medical treatment and who fulfill the criteria achieved the reduction of heart failure hospitalizations. So I think it's almost similar, but they have used the word not eligible for surgery. Okay. Percutaneous 2B is percutaneous edge-to-edge repair may be considered to improve symptoms in patients with severe secondary MR not eligible for surgery and not needing coronary revascularization, who are highly symptomatic despite medical treatment and do not fulfill the criteria for reducing heart failure hospitalization. So we have a 2A and a 2B recommendation, but I think the 2A recommendation seems to be very similar to that in the US guidelines. Is that correct? Do you agree with that?
Absolutely, yeah.
Yeah. And that is good. I mean, it's good to have similar guidelines. Next slide. Now, the management of acute and chronic heart failure, you can see over here, we have the medical treatment, and the medical treatment now is classified. You see, what is important is since COAPT ended, there has been an increase in the on new classes of drugs which have been approved. So, like you have ASRB, beta blockers, mRNAs, and SGLT2 inhibitors. So, all of these drugs should be considered in patients with heart failure, with systolic dysfunction, and with secondary MR. So, the importance is that the importance of secondary MR has been recognized. That's important because remember, before these two trials, there was still a lot of questions of whether we should treat secondary MR or not. But I think now it's clear-cut evidence that treating secondary MR independent of medical treatment helps patients. The next thing is the therapy was only mentioned in the previous guidelines. In the 2021 guidelines, the therapy is fully recognized and integrated in the algorithm of treatment of chronic heart failure patients. So I think there's a clear-cut evidence improvement or level of guidelines improvement in the European guidelines for the use of MitraClip or TEER in the treatment of secondary MR. Next slide. So the management of secondary MR in the previous guideline, there was no algorithm. The recommendation remained the same for heart failure and valvular. So the patients in the heart failure and the valvular guidelines have remained exactly the same. Next slide. Finally, I think this is just new organization of optimal patient management. And this is important that they've talked about the heart valve center with multidisciplinary, clearly recognizing that more than one individual is required to understand and treat patients with valvular heart disease. Next slide. Next slide, yeah. And this is the same, basically showing the evidence of having patient-centered evaluation for interventions. So the heart valve center, the network, and how the patient can be treated. Next slide. So this is again clearly showing you the tiered system of the patient-centered evaluation for interventions. Next slide. Now for primary MR, the guidelines are still 2B, a level of evidence B. TEER may be considered in symptomatic patients who fulfill the echo criteria for eligibility and are judged inoperable or at high risk by the heart team. So it's very important to understand that it's not just inoperable patients. It is clearly it is both high surgical risk patients and inoperable patients. And the level of evidence is 2B. In the US guidelines, it's now 2A. Next slide. And this is the guidelines for the management of valvular heart disease, the 2 and ESC guidelines. And you can see clearly over here, if patients are symptomatic, they have primary MR, and they're high surgical risk, and their anatomy is suitable, TEER is safe but less efficacious. Their point is surgical mitral repair is preferred method of treatment for primary if a durable repair can be achieved. But TEER is a safe but less efficacious alternative that may be considered in patients who are contraindicated or high risk for surgery. And I think this is the summary of the secondary MR guidelines is that 2B should be considered in selected symptomatic patients not eligible for surgery. And C is in high-risk symptomatic patients not eligible for surgery and not fulfilling the criteria, suggesting an increased chance of responding to TEER, the heart team may consider in selected cases a TEER procedure or other transcatheter valve therapies if applicable after careful evaluation of a ventricular assist device or heart transplant. So this is a little bit complicated. And so I think the management of patients with severe secondary MR, here in patients with severe secondary MR, GDMT, including CRTD, should be the first step. And I think this is common for both in the US guidelines and European guidelines. And TEAR should be considered patients not eligible for surgery and fulfilling the criteria indicated for increased chance of responding to treatment. Now, and they've mentioned the COAPT criteria, so I'm very happy that they actually mentioned the COAPT criteria, because the COAPT criteria is the basis or the group of patients who we know benefited the most from transcatheter mitral valve therapy. What about mitral valve replacement and repair? I think tricuspid regurgitation is now clearly been shown to be an effective, is important. It is actually a prognosis, and we also now know that treating tricuspid regurgitation actually helps patients. And I personally feel that isolated tricuspid valve surgery is actually very high risk. And I think the indication for TEAR is going to be a much greater in patients with tricuspid disease. Do you agree with that, all of you? Hello? Next slide. Yeah. Thank you.
Wonderful. Saibal, I think this was the last slide correctly. I'm correct? Thank you very much, really, for this wonderful talk, and that you took us through the guidelines. And I think to make time sure, I want to ask you one small question, and also ask the audience to send in their Slido question. Saibal, first of all, thank you very much that you introduced us the MitraClip procedure 2005-2006 in Europe, because you and Ted Feldman were the proctors who trained us, and we, Rottbauer, Stefan Bardeleben, and me, we are actually the next generation which has been trained by you. Thank you very much for that training, Saibal. My question
I want to say this in the audience today, and I mean this. When I introduced primary MitraClip in Europe, you remember I did lower risk patients, right? And we had done not many patients with functional MR. It is the Europeans who first started this therapy for secondary MR.
Okay.
We did the COAPT trial, but it is true. I actually mean this.
Thank you, Saibal. Saibal, I have one small question. With the secondary MR, if you have a patient who fulfills the COAPT criteria, is it still important to have a surgical risk, or is it independent from the surgical risk?
No.
This is very important.
This is the difference. This is the fundamental difference between the European guidelines and the US guidelines. In the I don't know what is done in Europe, but in US, when you see a patient with primary MR, there has to be the patient has to be seen by a cardiac surgeon and a cardiologist. In functional MR, all that the patient needs to be seen is by the interventional cardiologist and another heart failure specialist. That can be anybody.
Okay. To make sure that
if you look at the words, the surgical risk is not mentioned in the US guidelines.
Okay. That's wonderful, Saibal. Thank you very much for that. To have enough time to talk together and to discuss later all the three talks, I would now ask Stefan van Bardeleben to tell us which body of evidence support the guidelines update. And Saibal, you are very welcome to discuss with us. Okay? Stay tuned. And thank you very much for your nice talk. And Stefan, please, we are very keen to hear your talk.
Hussein, thank you very much. Saibal, it's a great pleasure to interact. And I would now like to draw the line between the guidelines that you just mentioned. And I want to cite one of the US, Robert Bono, of the US guideline authors. And it's important to recognize that rather than dictating a one-size-fits-all approach, that we really have to evaluate the quality, but also to evaluate the scientific literature and to assess this for the individual benefits of the patient, because the guidelines cannot describe every potential interaction between the comorbidities, and I will show what this means. If we look back into the differences, and you just mentioned it, in the management of secondary MR, you see that the US guidelines there were much more particular and also looked into heart failure specialists, while the ESC guidelines simply looked at those patients who remained symptomatic once the guideline-directed medical therapy had been initiated, and this can be determined by the heart team. You can also see the adoption, and just in press is a new article on the transcatheter mitral valve therapy in the United States. And we were happy to publish 24,000 patients, but now 30,000 patients are coming from the US. And you see the adoption on the right-hand side, which was primarily driven on primary mitral regurgitation. If we look into the quality of life situations with the Kansas score, you can see that exactly in secondary MR, the change of 20 to 30 points is not reached by any medical therapy in the world. On the other hand, you see with the development between 2014 and 2019, that a situation that you already described the FDA hearing in 2013, where I actually presented the secondary MR part, that the safety, which was voted 8/0, is again driven and seen and further improved over time. And this has been nicely shown by Michael Mack, and this paper will come out shortly in JACC. It's currently in press. And you see that the 30-day mortality also dropped over time, and efficacy increased, as did quality of life score. So we have more than mortality. And this is just a summary, what you already showed, just to make it a little graphical. And this is the European guideline on TEER for secondary mitral regurgitation, which is now a level B. And you see the COAPT criteria, one of the studies you took mainly part in, and you randomized the highest patient number actually, also gained a 2A indication level of evidence B, while the rest still was kept in the guideline. And this was a huge discussion. What is also new is that for the first time in the valvular guideline, but not in the heart failure guideline, actually PCI plus MitraClip is a possible combination that was ruled out in the previous guidelines as a 2A indication only for surgery, which was CABG plus mitral valve repair or replacement in the secondary MR group. And this is completely new and was not copied actually, even though the guidelines aligned mostly nicely, it was not actually included so far in the heart failure guidelines. The principle of it all is unloading the ventricle, may it be by a parallel treatment in medications, or may it be by a treatment by a TEER device. And you see it's a very predominant disease, the mitral valve regurgitation, as you see on the right-hand side, which has doubled the number actually of aortic valve stenosis. You already discussed that we have two types of MR, but the rationale and the situation, what happens to the annulus is quite the same. So we have primary disease, but we have loose situations where we get dilatation of the annulus over time, and we have secondary MR. And it's very important to look at this data from Vienna, that we have not only ventricular components, which is predominant in secondary MR, it's about 85% of the patients, but we also currently recognize, and COAPT adapted to it during the 8-year or 7-year period of the study, that it actually took up the ejection fraction from initially 40/45 to 50%. And 50% is a unique group that also very often has an atrial component. I'll show that. So if we look into the details and sub-analysis of the COAPT trial, which mainly drove actually the December 2020, as well as the August 21 guideline updates in the US and in Europe, we know that this trial had been the largest. And one of the drivers actually to differentiate a 2A and a 2B indication was that even though it was the only trial to show such distinct mortality benefit, it was a very sustained mortality benefit. And as you can see, it was statistically significant, not only at 2 years, but maintained actually the gap at 3 years' time, even with a number of crossovers, and the number needed to treat to save a patient's life here. And this is all-cause mortality, one of the highest and most hardest endpoints we have. It is only 8. And if we look to TAVR, we have a number needed to treat of about 3. So these two treatments are far more beneficial to a small subset of patients than is medication, which needs 20 to 60 a number needed to treat to save a patient life, and which drives its significance over huge trials with 10,000, 20,000 patients, which was not the case in these device trials. The second thing is that we also have this year, 2021, very nice subgroup analysis, and one of those that is very interesting is ischemic versus non-ischemic disease. We remember that the CTSN trial network was negative for secondary MR in the ischemic cardiomyopathy world. And here, more than 60% of the patients were actually ischemic disease, both in the MitraClip plus GDMT, as well as in the drug therapy arm alone. And this is very important to remember. If we look into those patients, we see that the non-ischemic dilative cardiomyopathy patients are slightly younger. The ischemic patients are slightly older. They have a higher risk scores, and have, of course, much more situations like diabetes and peripheral artery disease. But if we look into the effects that we see on death or heart failure hospitalization, first in the non-ischemic group, where we thought this would work, we see a very nice separation already beginning at 3 to 6 months and maintaining over 2 years. And if we look into the ischemic group, we see almost the same, whereas only death has a later onset between 9 and 12 months to separate the curves. And this is a combined endpoint of death and heart failure hospitalization. So the spectrum is, as nicely shown in this publication, actually, the ongoing process of dilating ventricles and chambers, which can be regressed or stopped, as in the COAPT, where we saw no positive remodeling, but we saw a negative remodeling in the control group. So the disease went on while the other disease was stopped. And if we look at the effect, it's an effect of reducing the LV-EDP and the LA pressure, and this really drives actually the benefit. And I want to show this here with a functional MR with relatively preserved ejection fraction, and you see the huge atrium, which is larger than the ventricle, and you see that these patients may have V waves and that they benefit over time. And this patient was reduced in the BNP values by more than 70% and is doing well thereafter and has a New York Heart Association class 1 to 2. So I think this is very important. Now, Saibal, you're, of course, the man to be for the discussion later on. But what is also important is how does the effect actually of the reduction of MR influences the outcome? And we remember that the number of patients being free from a 3+ or 4+ MR was higher with 95% versus the MITRA-FR group, which only achieved 90% in this freedom. So how does this influence the situation? And here I simply show a pooled situation on the cumulative heart failure hospitalizations, which nicely show that it's important, especially to decrease the 2 steps, 3+ MR and 4+ MR. And this is true for both groups, medication and MitraClip plus medication. But what has not been highlighted, even at the recent congresses, was that the numbers at risk are totally different. If you look at the numbers at risk for the TIA therapy plus medication, you see that in the group 0 or 1+, so almost no MR, there are 200 out of 270 patients, and only 20 patients are in the group 3+ or 4+. If you look to the medication group, even though the curves look the same, you see number at risk at MR 0, 1+ is only 20, 1, which is 1/10 of the population, and the majority of the population, 70%, are in the group 3+ or 4+. So the effect is totally different, even though the curves look similar in this publication. And this has been nicely highlighted at a recent Congress. And here I put it in brackets actually to show this. And this shows also the combined endpoint. Before I showed heart failure hospitalization alone, but also if you include death, you still see this separation, and you see the massive difference in the number at risk. If we look more into details, you can see that the severity of MR and do not treat too late is also a very important point. If you look at the upper level, you see the result at 30-day, and below you see what was the baseline. And you see a statistically high significance that in the relatively good results, the number of 3+ MR was 60%, while it was only 40% in those who had not a successful outcome. Again, the numbers are totally different in size, but I want to highlight this. The interaction between the tricuspid regurgitation was not significant, but right ventricular systolic pressure, as well as the residual effective orifice at 1 month, was highly significant. And this shows you that the stability of a good result of unloading the ventricle, if you look at the MitraClip groups, remains with a large green bar, very positive, while the other side is more variable. And this becomes more clear if you look at these graphs. And here you see at the 0 and at the 2+ MR, you see that the left side, the device therapy, is far more successful than the medication group. And this is also shown in the blue graphic, where you see that over time, GDMT did not remain its positive effects alone, but that the device additionally was needed actually to gain stability in your publication. And we showed the same actually in a large cohort and a registry from the MINDS cohort in 606 patients. And there you see that your baseline volume load, which was driven by the degree of TR, actually influenced outcome over 5 years' time, whereas the reduction by the MitraClip had an effect over 3 years' time. Rhythm, sinus rhythm versus atrial fibrillation, did not play any influence on heart mortality outcomes. The next interesting thing in the COAPT subgroup was the definition that actually TR, severe TR or high pressure, was excluded. And this was unlike the MITRA-FR, which remained negative. And here you can see that the impact of a residual contraction of the right ventricle versus pulmonary artery pressure, defined by strain value over your right ventricular pressure, actually, or your PA pressure in millimeters mercury. And here you see the device group in dotted lines, and you see the medical group in solid lines. And you can see that even a bad ventricle with a MitraClip plus adverse pulmonary hypertension was as beneficial as the positive group with the medication. And the highest difference was between the good LV function and the lower pressure of the MitraClip, and this had the most beneficial outcome in the sub-analysis. And again, this could be also highlighted in registries. And this is a registry we took part in from the Munich, from the Leipzig and the Mainz group in the Euro-SMR and some Swiss centers. And you can see this was over 1,000 patients. And there you see the spline curve for mortality. And actually, arrow A, whether it was slightly below 0.3 or it was above, up to a value of 0.6, did not show a mortality difference. And this is also highlighted by some other current trials, and it's important to recognize this. If we look at heart failure hospitalization, again, TR plays a role, and here you see that in the COAPT cohort published and shown by Rebecca Hahn, and you can nicely see that MitraClip with a mild TR is the best group and best benefit, and that having more than moderate TR is worse, but GDMT even goes beyond those curves in both groups, and this is important to recognize. Now, what is the effect? And this shows you the different trials, and Saibal has already highlighted on that. We have to recognize the high-risk cohort for primary MR was done with generation 1. Everest 2 was done with generation 1, 9 millimeter arm length. COAPT was in between classic and NT, and now we have the EXPAND trial, which will be the next talk, and we have EXPAND G4, and we have new devices. What is the difference? The possibility to reach a 1+ or 0 MR is the difference, and also the possibility to stay below 2+ MR. And this is highlighted in the case example that I want to give you with a COAPT-like patient where you see had an infarction. This is ischemic type. He had an infarction in the circumflex territory and the apex. So he was diseased, had a 3-vessel disease, 2 infarctions sequentially, and he had a horrible a multi-directional functional jet where you see the valve is tethered. It has 1.2 centimeters, a bad outcome for repair in the surgical group. So what happened? We treated this patient with the latest generation clips as a good result here, and an even better result at the 1 month and 6 month follow-up. And look at the BNP value over time, and you can nicely see that this patient went from New York Heart Association class 3 with a 6-minute walk test of only 200 meters to a 6-minute walk of 350 meters and a low BNP value over time. So this concludes my slides on the clinical evidence, and I'm happy to hand back to Hussein for the moderation.
Stefan, thank you very much really for this fantastic talk and also the actual and new data. And in Slido, I didn't get any questions, so I would like to ask you one question, and the same question goes also to Saibal Kar and also to Wolfgang. So for secondary MR, do you think we should repeat the COAPT trial in Europe and the MitraFR trial in the United States? What is your thought about that? Saibal, first of you.
I definitely will not repeat the MitraFR trial in the US. No, I think as far as I'm concerned, it's unethical not to offer a MitraClip in a patient with secondary MR who still has secondary MR in spite of medical treatment.
Okay.
And I also like to also acknowledge the MitraFR trial. If you look at it very carefully, it was not a negative trial. Even in the patients with lower MR, if you look at the 2 or 3 year data, there is reduction in cumulative hospitalizations. So it is, I think it is the right thing to do.
Okay, Wolfgang?
Yeah, I totally agree. I think there is no reason to repeat these trials. And I think the most important issue is, and this is now, I think, part of the guidelines, is that there is no real other treatment option for functional MR. So the operation is classified as 2B. And so we need treatment for these patients, and COAPT, I think, is a very solid trial that shows the benefit. And I think with EXPAND, we get more and more data that patients with functional MR benefit from TARE treatment.
Okay, Stefan?
I totally agree. I think we should not redo these trials. The benefit, if we only highlight the quality exchange between the recommendations of mitral versus tricuspid disease. And if we see how the class 1 indication in the tricuspid therapy for surgery is based on evidence, if we put the same evidence levels for tricuspid to mitral, then automatically we will see class 1 and 2A indications actually for the current 2A and 2B indications for MitraClip. Because this is the first-line therapy, and I think a lot of the wording still is copied from previous guidelines. I think we should free ourselves in an update, and there will be a comment from the German Cardiac Society on the current guidelines. I think they are partially inconclusive, and they lack actually evidence levels in TAVR, in mitral, and in tricuspid valve disease, and they use different thresholds for the recommendations, which I think is unethical, because if they withhold a therapy which is outcome relevant, this has further implications. And I think political interactions between societies or nations in Europe cannot overcome evidence analysis in the guidelines. And I think this is a very important point that has to be addressed in an update within the next 2 years. That would be my point, rather than to invest another 6 years or 8 years having patients die, having patients suffer. And if we recommend iron for heart failure, we should definitely define and recommend TEER therapy for heart failure patients that remain on a 3+ or 4+ MR, irrespective whether they fully fulfill the COAPT criteria or they're borderline patients, because this has been nicely shown in registries on more than 3,000 patients. And I want to see how many device studies we have where we actually achieve 3,000, 6,000 patient numbers, and it's unethical to repeat them. So I'd rather reanalyze them. I agree that we need some repair MR data that we need on primary disease. As Saibal mentioned it already, we need further evidence for lower risk groups. but I would not reconfigure and redo MitraFR. No way.
Okay, Stefan, thank you very much for this wonderful answer. And let's move on to the next talk. What are the clinical implications and the benefits for the patients? And I think this is really a round webinar. So, Professor Rottbauer, we are very keen to listen to you.
Okay, here you see my slide. Okay, so I think I'm trying now to put everything into clinical practice and show you some real world data, not a randomized trial. And with the EXPAND studies, we have this type of single arm trials or registries that allow us to get an impression of the real world situation. And these trials basically used COAPT to define well the outcome of these patients regarding MR. These trials included all comers, so we have all types of mitral disease within these registries, and within the registries, even novel technologies, modified clips were used and analyzed. So let me start with the EXPAND study, and I think everybody here is aware of the data. Two different clips were used, the XT and the NT clip in this trial. Over 1,000 patients included, and I will focus now on the 1 year outcome data. You see here the patient characteristics, and you see them also differentiated in 2 columns for the secondary MR in the middle and the primary MR. And I just want to highlight the arrows for the patients. They are different. For primary MR, about 0.40, and for the secondary MR, 0.30. And also the end-diastolic volume, I want to highlight, is a 180 ml for the secondary MR group, and for the primary it's about 120. Just to put it then in the context of the COAPT trial, I think these are important numbers to highlight here. So here you see already the first very impressive outcome in this all-comers study. You see a reduction of MR to 0 grade 1 or below in almost 90% of the patients in the EXPAND population, even after 1 year of follow-up. And these are COAPT data. So this is really a very excellent outcome. And I think Ralph already pointed that out, that we can do much better than we thought in reducing MR and leaving MR behind. So really excellent data. And just don't focus on the details. And this is also shown for both types, for the primary MR type and the secondary MR type. We did even a little bit better for the secondary MR type, and I think this is not surprising because treating primary with TARE might be once in a while quite challenging, but very, very robust outcome on residual MR. When you now translate it to mortality and bring it into context with other registry, you see a 30-day mortality in the EXPAND trial of 2.3% and a 40.9% mortality rate at 1 year, also a very, very low mortality. When you look at the subgroups, and this allows then the comparison to the COAPT trial, and the red line stands for the secondary MR group in the EXPAND trial, then you get a 1 year mortality of 70.7%, and when you compare it to COAPT, it was 18.8. So similar outcome results in a real world setting. When we now look at heart failure hospitalization, I think this is a really strong outcome parameter, also now used for medical therapies. And here we see a dramatic reduction of rehospitalization of these patients of 63% in the EXPAND population, even much higher than in the COAPT trial with 52%. So I think very impressive. And again, it's not surprising. Rehospitalization rates are different between functional MR and structural MR groups. And this is also found in the EXPAND trial that makes the data even more valid, at least in my view. The NYHA functional class is also dramatically reduced. More than 80% are in NYHA functional class 1 or 2 at 1 year follow-up. Similar results in COAPT are shown on the right lower border. And quality of life, this was already highlighted, dramatic increase in points, 21 points increasement in the quality questionnaire score and the Kansas City score, in comparison to the situation before the treatment of these patients. So just one issue regarding the use of XTR and NTR. These are just trendy data, I would say, we have from the EXPAND trial, so there's nothing randomized, and we don't know why one clip or the other option was used. But overall, what we know, and this is very robust, is that we don't get increased transmitral gradients by using the larger or the longer clip arms, the XTR clip, in comparison to the NTR clip. And I think this is an important message. And you can drive this even further, although the numbers are pretty low, but there seems to be an advantage to use longer clip arms in treating primary mitral regurg. And I think this is something very important because it applies to certain subtypes. The more severe the MR is, the better the XTR performs in comparison to the NTR. Larger prolapse gaps shown on the right, and also complex anatomy seems to favor the XTR clip in comparison to the NTR, although it was not randomized. So there's clearly an advancement. And let me now finalize with the EXPAND G4 study and data that was recently presented at TCT. And you see EXPAND G4 was started with the generation for the clips, and instead of making the arms longer, they made it now wider. And these are now the NTV and the XTV clips. We have now outcome data, 30-day outcome data on 529 patients. And then what are the key issues? Don't focus on the slide and the details, but the EXPAND and EXPAND G4 is pretty comparable regarding MR severity. This helps then in the end maybe to pool the data. Again, this shows the comparison implantation rates are far above 90%, 97%. Procedural success rates are very similar to EXPAND. Far over 90%. And I think what's so interesting is that the device time is even going down and down and down, although we have now different clip sizes and do more challenging things. The device time is now 34 minutes in EXPAND G4. That's pretty impressive, I think. Regarding outcome, I think it just confirms what we have already seen in the EXPAND trial, a severe impact on reducing MR. 90% of the population are, so far in a 30-day outcome, have a mitral regurg of grade 1 or less in the G4 study. This also applies to NYHA functional class, the same pattern, severely smaller numbers for NYHA functional class 1 and 2, and an increase in quality of life scores, again, 20 points or even more. I think what's interesting is what type of clips were used, and I think it was to the discretion of the implanter. But you see that over 70% of the clips were the wide clips that were used now in the EXPAND G4 population. And I think what's interesting is that there is a certain type of differentiation. So again, for the primary, where we had from the EXPAND trial first data that there might be an advantage of the longer clip, the XT clip. More XTW was used in the primary MR, and in the structural MR group, we had the secondary, sorry, I said structural. In the secondary MR group, more NTV was used than XTV, but in most of the patients, the wide clips were used. And the other thing that's a little detail, but the Gen 4 gave us the opportunity for independent grasping, and I think this is quite surprising, but this also tells us that the study centers are very experienced. Independent grasping was only used in 5.3% of the patients, but as a secondary approach to get better leaflet insertion on the anterior, the posterior side, this is shown in the upper graph, was used in about of 70% of the patients to get even better leaflet insertion. But complete independent grasping, I think, is not as necessary in mitral position as it might be in other valves, such the tricuspid valve. So, and I think this is then the last slide. Regarding gradients, we don't see any signals again that a wider clip or a longer clip gives us more mitral gradient after the procedure than does a shorter or less wider clip. And this makes us very confident. So from my point of view, I would summarize the data from EXPAND that they appear to be very robust because they're COAPT controlled outcome data in a real life and an all-comer setting. I think this is very, very important to the community. The technical and the clinical outcomes in these registries are really excellent. And I think what's very helpful is that all the data that's coming from COAPT is confirmed independently. So the reductions in endpoints are very, very, very similar. And this is basically repeating COAPT. I think you could come to that conclusion from that. And the technical improvements that were introduced within these registries appear to have really a positive impact on patient outcome, especially in regard to MR reduction. And I think we are pretty happy that we have now these different clip options to treat our patients. And with this, I want to stop.
Thank you very much for this really fantastic talk, Wolfgang. It's really fantastic. And we have 3 more minutes, and we have also a question. Wolfgang, a question comes in from a colleague from Italy, Gianluca Tiberti. He's asking, what about the use of MitraClip in acute mitral regurgitation, for example, early post-MI severe mitral regurgitation? What's your experience?
Oh, so we do this quite frequently, to be honest, in Ulm. Although I think we don't have large evidence to do it, but usually the patients with severe MR on the respirator, they don't go to surgery on a regular basis, and if the anatomy allows to fix the problem, we do it to stabilize the patient and get it off the respirator. But I think these are issues that have to be considered then and being discussed in a heart team before you go for that. So we are not treating all the patients the same way, but we have a couple cases treated acutely.
We have 2 more minutes, and I have a question to you, Wolfgang, and also a short answer, please, from Stefan and Saibal. With the improvement of technology and the knowledge and implantation technique, should we repeat the Everest trial again?
Yeah, I think we should repeat part of the Everest trial because what was so successful for functional MR should be retreated, should be repeated for the primary MR. And the data are very encouraging, and I think I would totally agree. We should try to go there. And even the Everest data tells us that there is an indication for TARE in primary MR. So I would encourage that.
Great. 80 seconds.
I would not repeat the Everest-2 trial because the limitations of patient treatment were too intense. So 15 millimeters separation, we now know that the whole length of the intercommissural distance is far more important, leaflet height, etc. I think we learned much more. We have new devices. We have the Repair MR trial initiated at our center. And this is actually the new Everest-2. So if we come to the same conclusion that Everest-2 renowned is now a different name like Star Trek and Star Wars, I take the Star Wars Repair MR to do the same job. But I agree with you, and I said it in my talk, that we need to repeat the data on primary disease in a randomized fashion. For the secondary, we have Matterhorn, actually, but which was a little bit too small as a study.
Okay, 10 more seconds. Saibal, you will give us your last answer.
Well, I'm very excited that both of you guys are excited about the Repair MR trial, which is a modified version only for primary MR patients. And we decided to choose intermediate risk patients because we think we should go stepwise, right? High risk. And then we think there is equipoise in treating intermediate risk patients for primary MR with the MitraClip versus surgical repair, because there have been improvements in surgery. And as you said, Wolf, there's improvements in the MitraClip since the original Everest-2. So putting this together, I think Repair MR, I think, will be the next big step. Thank you very much.
I want to thank you three all for this wonderful lectures, all the audience on the screens, and also the PCR that they gave us this opportunity, and also to Abbott that they sponsored this session. Thank you very much. I learned a lot. I hope you also learned a lot. Have a fantastic day, and thank you very much for this wonderful webinar.
Thank you very much.
Bye-bye to everybody.
Thank you to PCR.
Thanks.
Bye.
Thank you.